All right. In the interest of time, maybe we can get started. Firstly, thank you everyone for taking the time. My name is Anish John. I'm an addiction psychiatrist and the medical director here at PSI Treatment Center for Addiction and Co-occurring Disorders. We do PHP and IOP levels of care. I know this is extremely appealing in the post-lunch hours to be listening to a presentation for the next hour and a half, and you're thrilled to be here. The goal is to make this hopefully an efficient use of your time and minimally painful. I do like to remind folks that this is also a perfect time for a nap, and if you want to just dial me down, there is no hard feelings. If there's someone visibly incapacitated or snoring, we may intervene. Outside of that, hopefully this is helpful. I do want to remind everyone, so from a CEU perspective, just as a reminder, and I'll bring this up after the presentation as well, you'll get an email from clinicalevents.org. You do have to set up an account using your email. This is, again, only relevant for folks who would be getting CEUs from this. So let's get things moving. I'm going to share my screen. The questions to streamline things and again make this more efficient. If there are questions that come up, please put it in the chat, and I think we will make sure that we'll have enough time to get into questions, concerns, complaints at the end, and hopefully kind of wrap this up. You can always email me afterwards as well if we don't get to anything. I'm going to share my screen now. I see even more people than I know. Awesome. All right. So getting right into it, the goal here is, I'm sure everyone here has some level of experience treating mental health and addiction. The goal is to make this an efficient and streamlined process that's data-based, and a quick review on just kind of understanding what addiction is. We know for a fact now, this is decades of research and data, that while on the outside looking in, it can be tricky because you're viewing someone kind of selfishly, from a hedonistic standpoint, continue to engage in the use of a substance or a behavior despite the mounting consequences, which in my mind is a simplified way of addiction when you're unable to course correct, despite knowing that this doesn't really work out well. It is a brain disease. It does affect multiple reward pathways, circuitry that definitely includes memory, motivation, lower and higher functions. And especially if we're looking at the top-down approach of just judgment and reasoning, does get affected. And this is tricky when you're looking at someone who's not consistently always making the wrong choices, but this is where that kind of unpredictability can be infuriating. We know that there's definite deficits there, but it's not that it fits a neat box where everyone reacts in the same way when exposed to the same circumstances or environments. It would be awesome if we were able to kind of swoop in, nanotech or otherwise, if we can switch a gene off that can just kind of cut this off at the knees. We don't have it yet, but that would be great. It's messy and multifactorial. The whole nature versus nurture conversation or discussion still is relevant. There is a strong genetic hereditary component to having a family history with addiction, and that it's around the 50% marker. So it's not an easy equation, and it's not that it's black or white. if you may have heard this before, I envision a glass on a table. There's the edge of the table. The glass could be kind of closer to the middle with someone with minimal genetic loading. If you have a strong family history or a little bit closer to that edge, this is where the environment comes in, which is a hand that's nudging that glass closer to the edge. And then at some point you have a scenario where, you know, the glass tips off and you've got someone who then is well within the throes of addiction. There is a lot of awareness now, and a lot of the data and the research is looking at early developing brains. These are across the board for mental health, not just substance use disorders. Adolescents and kids who are exposed to adverse childhood experiences are at higher risk for mental health issues, including addiction. The sooner that we can get in there, and this is where that kind of nurturing environment piece comes in, we're being protective in the long game. Neurobiology, and without getting too deep, these are, I think, regions that are important to know in terms of what's affected. By no means is this everything, but the basal ganglia, to start off with, in the light blue or teal. So this is the reward circuit kind of superhighway. This is where all of it's a dense collection of everything that's affected with healthy and unhealthy rewards. This is what is reinforced when substances come into play. The amygdala in purple, we joke in the field how it would be nice if we can just kind of bubble wrap everyone that needs to be kind of protected with some level of amygdala dampening, because we're all prone to anxiety, rumination, and kind of nervous energy. If someone is in withdrawal, that's even dialed up further, and it can be a pretty strong motivator for substance use when your amygdala is just lit up like a Christmas tree and you're trying to do everything you can to dampen that discomfort. Finally, the prefrontal cortex, which is in the front part of your brain, in blue there. This is your higher order, brakes in the car. If you know, and if your brain knows that this is not a good idea, you're looking at pros and cons, you're looking at past experiences. You walk past a stove with a kind of still hot light, you're not going in face first. And this is, as I mentioned earlier, tricky. We know for a fact judgment and the ability for that prefrontal cortex to make decisions is impacted, and it doesn't mean that they are completely incapable of making sound decisions, but time and time again, and typically in a progressive way, when it comes to addictive behaviors or substances, that decision making is flawed, which then leads to people getting stuck into this kind of hamster wheel scenario. The beauty, if you will, of what substances do, they mimic, they amplify neurotransmitters, which are chemicals in our brain and our body that are floating around, and it basically harnesses this in a way that we are not built to withstand. Right? And so why do human beings keep veering towards substances is because of the kind of differences in the magnitude of what this looks like to the brain. So in this picture here, they're using cocaine as an example. The first image is that's a nerve terminal, dopamine, you may be familiar with, which is a pretty big chemical when it comes to reward and enjoyment, and specifically the memory of what it feels like when you're in that space. It is something that is propagated when you're having a healthy experience. This is walking on a beach, eating shrimp tacos, let's say, and you're enjoying life. That dopamine is the gold or yellow kind of globes that are floating around there. That second image is cocaine, which is a stimulant. It is significantly amping up the amount of dopamine that's in that nerve terminal, and this is the difference. It can be as kind of varied in terms of the experience as if you are whatever you're into. You're at a Metallica concert. You're at a T Swift front row tickets. You're at a wall of speakers that is vibrating your entire kind of essence. That's how loud it is. And that's what substances look and feel like. And if you have a healthy reward that used to be prominent, which is basically like someone whispering in your ear when you're at a concert, um, who's going to listen, right? How is that going to be acted upon when your brain is literally being drowned out? The challenge when we look at kind of moving forward here. So human beings, as I mentioned, we're not built to withstand this level of flooding. There is no way that we are able to acclimate to such high levels of dopamine that constantly get flooded, amplified in an artificial way. And so what the brain does is it basically says, this is too much, we're shutting it all down. We're the brain, in a compensatory way, dials down dopamine transport function, sensitivity of the receptors in that area, and it basically renders the brain to a certain extent incapable of perceiving the effect of dopamine that still may be created but isn't really having a whole lot of play in the brain. And so this series of images, the first kind of brain imaging, the red splotchy areas are the dopamine transporters in a healthy person that you see there. That second image, and it's not even, so they're using methamphetamine as an example here, which is a powerful stimulant. That's not even an active use. That's someone who was stopped a month prior, and you can see how they have basically, minimal to no dopamine transporter activity. And this correlates to someone who is just miserable, right? The quintessential, nothing works, nothing matters, because they're really just biologically incapable. They're just not able to feel what was triggered before. And I guess the good news is that the brain, after a certain period of time, if it recognizes that this is not artificially being hijacked, it starts to get back online. You see here in that third image, that's a methamphetamine user, year plus abstinent. And so brain is back online. It's saying, okay, we can, get this going again. Splotches are as red as ever. And then the holy grail, which is what I put the question up here, is why can't, this is what we get asked all the time. I took a break. Why am I not able to go back to using, right? It wasn't always a complete train wreck. I had a good stretch of controlled use. This was something that was enjoyable. Shouldn't I be able to dip a toe back in? And this is where you'll get books or podcasts about cures for addiction, and I'm all for it. There's unfortunately nothing yet that we have definitive data on that is a cure. And this is where, in terms of like kind of bigger takeaways, is what we view as the chronic kind of medical model. This is not something that you kind of cure and move on from. It's much like any other chronic medical condition, needs ongoing support, treatment, and kind of guardrails as well. Typically, when folks have crossed that threshold into addiction, they may not immediately recognize the kind of devastation that they were experiencing before when they start to kind of explore, some of the earlier, I can do this, I can control it. What we do know is that this is a quickly progressive condition, and that this is something that will historically, for everything that we know, pick up and typically surpass where they were, and quickly they're right back to a scenario that was just as damaging, if not more. And I put, you may have heard the correlations of, this is just like diabetes. This is, if you have a thyroid issue, you need to treat it just like that. And that is the model, right? You can have folks who are doing well, right, with their diet and their kind of glycemic control, and then they're on vacation, or they're stressed, and things are not going as well. They're not taking their meds. They're not watching what they eat. I put relapse here not to conflate those scenarios, but from a medical model perspective, this is something that could be a factor in someone's recovery journey. Relapse is by no means required. There's a lot of folks out there who, if they're struggling and identify addiction to be a concern, they're in it, they're in recovery, and that keeps going. It can be something that is demoralizing, especially when you have the entire treatment team, you've got a family network that's trying to get someone better, and they're relapsing. It looks like they don't care, right? What's the point of all of this effort and energy if they're relapsing? None of this is going to work, and there can be an understandable inclination to flip a table and walk away. This is an opportunity, though, and from our perspective, there's commonly a lot of barriers to treatment approaches, to openness, denial or otherwise, to other kind of treatment modalities that could be helpful. And so if someone's struggling, it's a data point that we can then say, hey, this isn't working, right? You said you got this. You said you know what you want. You're only going to do X, Y, Z, but we have these other options. Can we kind of basically amp up the game plan and then get to a point where someone has sustainable sobriety effectively? This can be kind of a vortex to get sucked into, and don't mean this to be kind of demoralizing, and more so an optimistic view on, despite struggles and bumps on the road, people can get really to a place of healthy recovery. Data points and numbers I know can be pretty dry, and this is from the most recent kind of survey data. It's astonishing. We know that this is high kind of globally, and this is for us in the US. AMI here stands for any mental illness, and that's 18 or older. About 86 million people had either a mental illness or a substance use disorder. Comorbidity, which would be having both a mental health issue and a substance use disorder, is really more the norm than the exception. People may remember like dual disorders and dual disorder treatment versus straight substance use disorder treatment. It is really just kind of expected that there is some level of an overlap. About a third of the folks with a mental health issue had an SUD. I put some of the kind of correlations there when it comes to alcohol, depression. I think this was a question that had come up earlier as well. Bipolar disorder is definitely high in terms of comorbidity. It's somewhere around the 30 to 60%. They're looking at kind of depression specifically from a mood standpoint in cannabis. If nothing, I think really just hammering in on, you can try and get someone in and just pluck a substance out of the equation and hope for the best. But if we are not assessing for and treating co-occurring issues, it is a massive chink in the armor there, and really gets to struggles and hurdles even after the intensity of treatment ends. Opening this up to how, in terms of treatment of, and the word professional is used broadly here. There's a lot that in multiple different fields we have no control over, and it feels like it's really only getting worse, and this really compounds pre-existing concerns. You can look at something like the pandemic as the perfect storm, where I'm sure a lot of folks may have seen that was it, right? That had folks who were somewhat floating and coasting, and it was enough to kind of push people over. These are unfortunately practical challenges that may not necessarily be kind of fixed with a magic solution. If nothing else, it's awareness, not only in terms of prevention, but looking at what not to do. We'll get to that in a little bit, but if we're looking at just kind of reentry, and how to get someone to an optimal long-term outcome. I'm going to do like a proof of life check-in just to make sure that everyone's okay and that we are good to go. Wake people up as well. All right, good. It's weird that I can't see you guys when I'm doing this because I see the full presentation screen as well. But if nothing else, breaking it up I think can be helpful. Let's get back in. Also, I think it's maybe unmuted. Appreciate whoever that was. I think we are good to go. Let's jump back in. I see breathing and nodding, and that's a win. I'm going to run for it. Okay. So, what do you do when you've got a question, you've got someone who is clearly struggling? There, folks may be aware of interventions and people feeling kind of hoodwinked and ambushed. And there's a lot of validity and emotional impact that comes from an intervention. At times, what we call in our world an MCAP, which stands for Multidisciplinary Comprehensive Assessment, which is basically a kind of a team approach of figuring out what exactly is happening, right? So there's an identified concern. This is brought by concerned parties, whether it's a loved one, an institution that they're working at, and they basically come in saying, I'm here to figure out what the issue is. People think that I'm struggling, and this is the benefits of it is that it can feel, and it should feel, like it's an unbiased, independent review of facts and data and multiple kind of perspectives, and I'll get to who all are involved. And they're able to, with some neutrality, present themselves in a way that they feel is accurate. It's almost never the full picture, but they're given rather that opportunity. Multiple components to an MCAP, right? You've got a really broad review from an assessment standpoint. You're getting multiple data points, and you're also screening for not just addiction, which is, if we're looking at our own, it's a percentage of folks that we see, but it's not always that someone has a substance use disorder. And if we're not, again, opening up the possibility where we're going to be missing things, usually psychiatry, addiction psychiatry, forensic psychiatry, if needed, is involved. There is a medical evaluation and a component to this because, again, of comorbidity and making sure that we know what can be influencing the scenario and or worsened by untreated mental health issues. Chronic pain, I'll get to that as well. But these are, it's a kind of a battery of things. It's usually a 3 to 5 day process. Personality testing, there's neurocognitive testing that we'll get to as well. Boundaries are sometimes the initial kind of flag that comes up when you see people who are really not operating in the spheres that they should, and it brings up questions of just judgment and reasoning. I mentioned neurocognitive assessment, and this is a key factor. I would say even more pronounced when it's a safety sensitive provider, if you're thinking of pilots, healthcare providers, so on and so forth. Toxicology is key. You're getting a narrative of what the individual themselves is describing in terms of their use, and then you match it up with a variety of testing that can include urine, blood, hair, nail. We'll get to that a little bit further as well. But it's important to get the full picture. Um, Collateral information. So a key factor, as I mentioned, when someone comes in, is you're getting one point of the picture, if you will, and commonly there's a lot more information that's underneath. If you're thinking of the iceberg floating there, we don't hinge everything upon collateral, but it is important. You're not going to be able to build out the entire scope of the struggles that someone has without verifying that we've heard this from different perspectives. If, and I'm getting ahead a little bit here, but that process with the MCAP is complete. There's enough time to verify documentation, look for toxicology, see if it correlates with the narrative that we have been given. There may be a scenario that someone is struggling with an eating disorder. There is a medical condition that's affecting cognition. They need a further kind of brain imaging. There has to be additional maybe individual therapy. Trauma might be in the mix. So not always that someone has a substance use disorder, and the goal is not to shoehorn someone into a diagnosis or a treatment setting based on presumptions or assumptions. If treatment is indicated, I think this had come up also as a question earlier, and honestly, ASAM, I think UPC had been asked. We don't use the UPC, and it's typically ASAM that we use. We can spend kind of hours on this, which I'm sure is scintillating, but the idea is that there are multiple dimensions, and you're trying to be as objective as you can be. These are some of the changes that came up from the third to the fourth edition. And I would say big takeaways are that we're trying not to base this off of pre-existing arbitrary, this person needs this for this long, and doing individualized care, which I know is kind of a buzzword and somewhat cliche, but it really is helpful to recognize that not everyone is going to come up with the same issues. However, I will say that there are standards of care for a reason, and you want to make sure that everyone with severity of, I would say, at least moderate to severe of a substance use disorder is afforded the opportunity to get good treatment, which we'll get into as well. There are a variety of levels of care, and you may be aware of this, and I just throw this up there from a visual standpoint, all the way from your individual outpatient settings to long-term contained, more circumscribed treatment in a residential setting. And not everyone needs either or, but it's again finding what that individual needs. When you're looking at someone coming in for treatment, and we're past the what is the question, and I don't have an issue versus this is a concern that needs to be treated. Again, making sure that we're not missing anything from an assessment perspective to treatment. You're using, and we'll get into all the screening tools out there, but making sure that you have validated measures. If you're not asking these questions, a lot of the times patients aren't going to be telling us a whole lot. With prescription monitoring, which has been a real boon for us, it is easier, I would say, not always kind of a slam dunk, but we can figure out if there are other substances, controlled or otherwise, that are being used. What's tricky and is difficult to diagnose, especially when someone's coming in early use and intoxication withdrawal, is that this can masquerade as a lot of other conditions, right? There's anxiety, depression, bipolar disorder, all of which can be mimicked by active use and withdrawal. And if we aren't careful to give enough time for an individual to acclimate, get through post-acute withdrawal, let the dust settle before we figure out what actually we're diagnosing, looking at timelines in terms of what was pre-existing before, let's say, substances or addictive behavior came into play, and then we can accurately treat what's happening from a symptomatology standpoint, which basically makes it difficult to do accurate diagnostic kind of discussions earlier on in the process. I want to mention here, and this in and of itself is a whole other kind of topic we could delve into, but process or behavioral addictions are tricky because it's not like you can just swoop in and say, cocaine's an issue. We need to obviously stop using cocaine and then, figure out what else is happening. In the US, gambling is still the only currently recognized behavioral addiction in our DSM-5. That will likely change soon. We have conditions for further study, but this is now tried and tested, decades of data. There's no substance entering the brain. However, all of the regions that we talked about earlier are affected. Someone is unable to, despite jobs, homes, families being kind of wrecked, pull away from the allure of gambling. There is, I think we are in for a bit of a ride here because sports betting is blowing up, and just how easy and accessible it is for anyone to get on an app is somewhat frightening, and especially going back to what I said about early developing brains. You have kids exposed to any level of what they call variable ratio reinforcement, which is the unpredictability of a reward when it comes to gambling. That is extremely loud in the brain and difficult to ignore. So we have kind of challenges ahead of us. It may be unrealistic to be able to treat everything at the same time. But if we don't know, and if we're not asking these questions, these are clear areas of vulnerability that will flare. And sometimes there's a paired process of a substance with a behavioral addiction as well. The ICD in 2020 had confirmed compulsive sexual behavior as a diagnosis. We see a fair amount of that as well. Gaming disorders was a condition for further study, and that you can open that up to internet use. I think we're all at this point doom scrolling. I throw this up here recognizing how ironic this is that I'm even mentioning this while we're on a screen here, and at some point kind of propagating our tether to these devices. It is a reality that we're all spending a whole lot more time online. This is not to say that, and this is where there's percentages of the human population that don't get sucked in, right? We all may have the ability or the time to, whether it's Instagram stalking or doom scrolling, and then you move on with your life. Much like substances, there are a percentage of folks who will struggle when it comes to whether it's gaming or just getting sucked into what can be kind of a toxic, kind of a vortex where self-esteem, depression, anxiety, and if you've seen any of the documentaries out there in terms of what the algorithms have been doing in terms of social media, it is terrifying. But again, it's looking at vulnerability and not painting everyone with the same broad picture. Co-occurring disorders. Again, as we were talking about how crucial it is that we're not missing the kind of genesis of an issue. We're seeing trauma being more the norm, again, than an exception. Chronic pain can be tricky, whether it's related to pain medications or otherwise. Eating disorders, I mentioned here, there's actually a lot of overlap when it comes to the neurobiology. It's unfortunately pretty siloed in the treatment world. And so we're looking at tagging it, making sure that it's something that someone is tracking. From our perspective, how do we keep the continuity going, and if it's basically transitioning from one type of care to another versus even levels of care. If, and we see this happen all the time, there is an undiagnosed co-occurring concern, this can be going back to what we do when relapses come up. This is a question we can all ask, is what are we missing? And is there an area that we're not treating that then leads someone to struggling with a substance, which is then flagged as a relapse? Drug testing. So when you're in treatment, and I think drug testing and toxicology is the cornerstone of what we can do efficiently from a substance use disorder treatment standpoint. We can, and this is not to get into transparency and they're always lying. I mean, it's part of the illness, right? Their brain is going to protect them in any way, including the lack of transparency. And so having what we call the universal expectation of there is going to be some level of tracking and accountability is key, and to use it as a therapeutic tool as opposed to this kind of punitive fear-based we're going to catch you, which really doesn't do a whole lot, and it doesn't really help either, because if there isn't a feeling of safety and trust, someone's not going to be able to work through the kind of barriers to actually allowing a treatment team in. It can be helpful to have objective data, and we've seen, I'm sure you folks have seen as well, denial can be astoundingly kind of fortified, where you have numbers that just don't make sense, and someone can be really digging their heels in. Unfortunately, it may take some time, but it's helpful to have objective data and looking at, and we get to this a little bit later, the comprehensive nature of testing, because again, if you don't know what someone's using and if you can't track and test for it, you've got a big chunk of kind of risk right there, which takes me to, and this really has exploded, NPS, or novel psychoactive substances. So we have, and this is not new, for basically forever, humans have found ways to create new compounds. In the NPS world, it's tough from a regulatory standpoint to keep up with what labs are kind of pushing out there. If you remember, even in the days of synthetic cannabinoids, there was a new chemical formula that was popping up on a regular basis, and it's tough from a regulatory and a tracking and a testing standpoint to pick up on this. There are more options when it comes to what they call designer drugs in terms of testing that we have used, and you can kind of send samples out. It's not easy, and some of it can be pretty cost prohibitive as well. I think it helps to at least know and to be able to ask about use of other kind of non-traditional substances, and if nothing else, it puts a flag in the brain of a patient that they're at least aware and they're tracking and looking out for things, because all a mind needs, especially in active addiction, is a loophole and a trapdoor, and it's almost kind of irresistible at that point. The dark net, which I'll get into in a little bit as well, is not, so this is, and you may know, it's kind of a decentralized, kind of hidden behind or underneath the regular internet. You don't need necessarily to be kind of a savvy tech bro to be able to access this. We had folks ordering like GHB analogs that they were getting on Amazon. There are so many labs out there online that will ship anything and everything to a residence, a post office box, and it's not that someone needs to camp out in a dark alley anymore. You've got so many ways to really alter your mind, and this is the dark net that I was talking about. Cryptocurrency has made it even trickier in terms of funds and tracking where this is being kind of financially sourced from. The 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 reality is humans are going to keep finding ways. You may have seen or read about this. This was in Cook County Jail here in Chicago. The newer wave is spraying lab created compounds onto books and pages and even legal documents. And that's what's getting into jail settings, and people are basically using them, kind of ingesting, smoking, and getting pretty unwell, and potentially with lethal consequences. So this is kind of a moving target. We just have to be aware that we're not going to catch everything. That there's a fraction of what is real that we're getting from our patients in real time, even with random urine drug testing. And this is just a reality, right? We just have to be comfortable knowing that we're maybe not getting the full picture, but it's still worth it to continue, along this path. I throw Sobalink on. You folks may be familiar. So portable breathalyzers have been around for a while. I think they've been somewhat of a game changer in treatment settings, and even if you're looking at kind of ongoing accountability, these are devices that ideally are portable. They're even smaller now that you see here, and there's a few different companies, Backtrack being another one as well. This is not infallible. The point here is for alcohol, there are windows of time that an individual knows that they're expected to be blowing into this device, recognizing that someone on the other end cares and is tracking this. Now, there's facial recognition, so it can't be like their dog that's blowing into it. Ideally, it is the human being themselves. There are ingenious ways that people may try and circumvent this, which, so be it. For the most part, it is a fairly reasonable data point that we can at least get real-time tracking on how much alcohol is in someone's kind of bloodstream, and from a safety standpoint, this can be pretty helpful. It can be reassuring to loved ones, family, friends, when there's so much bitterness, resentment, and mistrust, suspicion that comes with this whole process. And we try not to like directly involve family members, because then you're getting people into somewhat of a policing role. But it's a relief, right? They're saying, okay, someone's tracking this, we'll know, or we'll be notified, and they don't have to go into this investigator mode of is this person under the influence, altered, am I being kind of hoodwinked in some way? It is not infallible. People can put this down and do whatever they want. People can try and game out specific strategies, whether it's time frames, how much they can actually use and process and metabolize before it's read on the breathalyzer. I view all of these as tools if you remember the Swiss cheese model of just trying to kind of block out as many pathways to relapse as you can, and not relying on just one or the other. I'd mentioned toxicology. Again, this is a whole other area too. So the look back windows can be helpful, again, to set a benchmark of this is factually what's showing up versus what you may have been comfortable sharing. It also can be a baseline on which to kind of to compare and contrast future concerns and questions about someone using versus not. The PEth test, let me go back here, is so phosphatoethanol is a compound that's created specifically when alcohol and ethanol is consumed. It is, I would say, one of the most sensitive and specific biomarkers we have out there. And it's specifically sensitive to either escalated drinking in general or spikes, and that would be binge use. And it's helpful because we have basically a 3 to 4 week look back window, and for folks who are kind of drinking heavier, that lasts even longer. But this can be an additional layer of of accountability, again, that someone who's struggling with addiction is registering that it's not just about, let's say, kind of figuring out how to beat the breathalyzer or waiting long enough to where something isn't picked up on the urine. There are longer term strategies that can pick up, right, use. And if you're looking at this as it is therapeutic for an active brain and addiction, to know that some of these doors are closed until they build enough of a recovery reserve to be able to work through this and lean on recovery supports, therapy, psychiatry, and so on and so forth. I mentioned neurocognitive testing when we were talking about the assessment, the MCAP piece. This is helpful even in active treatment, and especially when we get to kind of transitions to work. There are a lot of cognitive, you may have seen something that looks like this with the computerized cognitive screeners that are out there. That can be helpful. This is not the be all and end all. And I just mentioned this to highlight that there are limitations to some of the computerized screening options. There may be a lack of what we call kind of matching. So especially if you're looking at the professional world, there's a lot of masking. People can have a pretty high baseline intellect. There's a lot of years of education and training. And so a decline in neurocognitive function may not necessarily be flagged as something that is abnormal, just because what we call premorbid functioning, they started off at a pretty high level. If you don't have formal in-person neuropsychology evaluations, you may miss some of this. And by no means is that across the board, but if there's a question, clinical or otherwise, we typically advise folks to then move forward in further testing, and that would be non-computerized in-person batteries with then follow-up as needed. Sometimes you have to wait 3 or 6 months for the acute effects of a substance to not be playing a role. Med management. So this can be tricky in recovery circles. You will have folks even in the treatment setting that have different opinions. We have a lot of data on what's evidence-based and what's safe and what's not. In general, as I mentioned earlier, my goal is streamlining, right? There's a lot of meds that people come in on, especially in active addiction. Substances are kind of muddling the waters. You want to try and clarify, let the dust settle, peel off what might not be helpful, and not just continue medications that someone has been on forever just because they're on it. In general, and this is what you're going to hear and see in treatment settings for substance and co-occurring mental health, is just not to go down the route of sedatives, let's say like benzodiazepines or Z drugs for sleep. Stimulants, this is another kind of hotly contested conversation. ADHD or otherwise, psychostimulants are tricky, even if someone doesn't have a specific stimulant use disorder. You may hear different schools of thought on how, similar to, let's say, an opioid maintenance regimen, that might be helpful. It's tricky, and clinically we don't really see that pan out. And so in general, if there are focus, concentration, executive functioning concerns, with a formal ADHD diagnosis, and that's another factor because a lot of this is survey-based, or they found like an online clinic that automatically diagnoses ADHD and therefore they have access to psychostimulants. A lot of the times that's not an actual legitimate diagnosis. Avoiding and using non-stimulant approaches is what we would recommend and we try and strive for. MAT, or medication-assisted treatment. So the major concerns that you will hear is, I would say, specifically in the world of opioid treatment, although in some recovery settings, you may hear that it is ill-advised, right? You're trying to get off of substances. You're supposed to do this on your own. You are taking the easy way out by using these medications. And that's just not true, because again, we're not looking at a cure. We're looking at tools that can help someone cope, especially in early recovery. If we're looking at these are primarily kind of anti-craving or impulse control medications. And so, which is for alcohol, you have, and these are the two biggest, I would say, categories. There's overlap with other substances in terms of what we can use for cravings, but that's where the discussion is not that this is required for everyone, nor is this something that should never be explored. It is, what is the individual going through? How much are they struggling? How high are their cravings? What do they need short term versus long term? I know there has and there continues to be concerns about opioid maintenance, and that would be, so naltrexone's the blocker, the antagonist. Methadone and buprenorphine are opioids themselves. The idea is that they are longer acting, they're safer than heroin, fentanyl, what have you, and the idea is that for some folks, their base kind of set point is altered, and they may need some level of an opioid to be able to function. And the distinction there is you're trying not to get someone high, but you are getting them to a point of they are functioning. It's not altering them. They're not impaired. Cognition is not affected. It does not have to be long term. It can be used from a detoxification perspective. It can be used short term. This is also where it's really patient centric, because I'll have some folks who are hell bent against staying on it, and then we work with it. We try and look at risks, and does this make sense now versus later? And some folks who may need to be on it longer term, as long as we are weighing risks and benefits and a safety profile concern, this can be used safely and effectively. I've mentioned this as this is now everywhere, and I know there was questions about this as well. So we're in a whole new world of GLP-1s where it's a matter of time where this is at a gas station, and we're just filling up on whatever is the flavor of the month. And not that that's a bad thing. There are benefits, and so all of you may know. So this is from a cardiovascular standpoint, weight management or otherwise. There is true benefit. They have found that there are potential kind of targets here that can be really relevant to us. You're looking at satiation, right? And they look at food, and you can see how that makes sense. Food and addiction, or addiction to substances rather, there can be a way. So you're reducing intake, you're stabilizing the reward, the nucleus accumbens, which is a key factor in that reward circuitry. That dopamine release is being modulated, and so it is early though. There are benefits. Some of this is promising. I put this up here in terms of specifically with alcohol use disorder, and they're looking at risk of hospitalization. We don't have randomized control trials to be able to say that this is going to help you and this is something that we recommend. If there are medical comorbidities that would make sense to have someone on a GLP-1, so be it. But I would be hesitant to just directly say that you have addiction, you should be on this. There could be benefits, as I mentioned. Right now, so semaglutide, which is Ozempic, Wegovy, has the highest kind of correlation if we're looking, and this is specifically with alcohol use disorder. Or liraglutide is one of the others. Not all of them. So basically, not all have the same potential benefit when it comes to addiction. But I think this is the kind of newer phase of addiction treatment that's ahead of us. We are just unfortunately not quite there yet to do this in a safe way in terms of direct recommendations for use. Side effects, and we see this as kind of a big hurdle where folks try it and quickly get off. GI, so nausea, vomiting, GI discomfort, I would say are the most common. Gallbladder diseases come up. There are some CNS changes. Fatigue and dizziness in general. Hypoglycemia has come up, although maybe not as correlated. If nothing, I would say that this is not something that will work for everyone. It could work for some individuals. Ideally, it's not being used for addiction specifically, and there is another medical target that is being addressed. And if it helps, well and good. And hopefully, we will know more. In treatment, and so this is from a purely practical standpoint. I mentioned this on our end. We are constantly battling insurance, and when we have these peer review calls, I got to psych myself up, and you have death metal playing in the background so that you're revved up to try and essentially fight back on some of the at times ridiculous denials that we do here. It is their job, right, to try and I guess figure out ways to maybe not cover what they're supposed to, and this is a factor that we are reviewing, going back to even kind of criteria and ASAM criteria, to make sure that we have objective data to support why we think someone needs the treatment or the level of care that we are recommending. In our world, there's a lot of other factors at play that really would necessitate someone to get a solid treatment stay they may not have been actively using, and quickly that can become something that is basically used against insurance coverage. Again, I merely flagged this so that, and you may be aware of this already, these are hurdles that can be surpassed, and there's a lot more supporting data to really kind of highlight why there's something to be said about levels of care and step downs that make sense, duration of treatment also that is meant to be effective. Regular use, and this goes again to kind of maybe date of last use. Binge use is may not seem as tricky as someone waking up and drinking or using every day, but can be as challenging. Also, something that could kind of come back to bite us in terms of just treatment or coverage. Cannabis, we can spend a whole bunch of time here as well. We see, and I will clarify that this is not getting into medical use of cannabis or decriminalization of cannabis. The potency of what we have nowadays is astronomically higher and different than what it used to be. We know it's a substance that creates the same levels of concern, right? So cannabis use disorder is a real thing. We get a lot of folks who say, I'll look at my drinking and my cocaine use, leave my weed alone. We don't see that to make sense, and so it opens up a real kind of area of vulnerability, either for someone to skate back to their substance of use, or if the substance itself has not been a problem in recovery, your brain's trying to latch on to really anything it can, and that quickly becomes something that kind of morphs into its own issue. We also see folks coming in with primary cannabis use disorder that's just kind of debilitating, right? They can't really just function. In general, there's a whole lot out there in terms of the lobbying and really the money that's involved in the industry. And so I think this is continuing to change. From a treatment perspective, it's fairly straightforward. I throw this in there. Some of you may be familiar with prescription digital therapeutics. So the idea that, going back to kind of all of us just on our phones all the time, these are powerful computing devices, right? A lot of really space that can be used not only for problematic use, but this world of prescription digital therapeutics effectively is utilizing and harnessing this. If we're going to be using this anyway, why can't we deliver mental health interventions? If folks are familiar, so CBT, cognitive behavioral therapy, earlier on was first adopted, regular internet-based options that then went to different kind of apps. AI is throwing all of this also kind of in a loop, because where do we draw that line? And perhaps all of us, including myself, will be obsolete, but we're not there yet. So we'll see how this pans out. These can be effective tools to retain someone, to reset Earlier on, we had kind of used this as well. Unfortunately, they're on pause. They've had like funding issues, but the premise was sound. You've got someone who's plugging into their phone daily. There's short CBT oriented modules. They had looked at reset for opioid use disorder and just reset for substance use disorders in general, and it found that not as a replacement, but it did help retain folks in some sort of a recovery track, which is helpful because you're not asking them to do this for hours. You're doing quick kind of tune-ups when it comes to skills. What I thought was pretty cool was a craving tracker that had a visual. It's kind of like almost looking at a diary, right? You get to see a visual representation of when you struggle, what are patterns that might be helpful. From a mindfulness perspective, it's just keeping you in that headspace. When this first came out, they were looking at insurance covering it for 30 or 90 days actually, and you've got a clinician who's on one end of the portal and the patient who's plugging it. There's a lot more that's coming up that's depression, anxiety, and trauma based as well. So I think we will soon start to see more. But this is it was interesting because it was the first addiction or substance use disorder related app that had come out in this digital therapeutic world. um, as we look at just why this kind of weird lizard guy's on the bike here, the point that I want to go back to again is the chronicity of addiction in general. It is very understandable for human beings to come in. Things are not going well. This is the darkest phase of their life. They want nothing more to, okay, I'll do the work now, and then I want to flick a match behind me. Michael Bay style, everything is blowing up as I kind of zoom off, and I don't want to think about this again. I don't want to revisit this. This was a painful part of my life. And I get that. I wish that could make sense. This is not, an infection that you finish a course of antibiotics, you're done and you walk away. Much like any of the other medical conditions, if we don't at least have some level of guardrails, follow-up, support, therapeutic or otherwise, this is where we struggle. Globally, we don't do great when it comes to addiction, and this is where much appreciate to all of you. The stigma, the misinformation, and all of you are actively participating in propagating against that is key. And as much as we can, our continuing care approach at PSI is to keep people plugged in as long as they are willing. This is based off of, and bear with me, some of you may know this already. So we have now a lot of literature and outcome data, if you're familiar with the professional health program model, that looks at the track. It's similar to what you may have heard for pilots, but it's basically safety-sensitive workers are connected with an organization that basically triages, that gets them into ideally appropriate intense treatment. For treatment duration is still a battle at times. That can vary, but basically adequate, consistent, and kind of intensive treatment, and then followed by therapeutic support, advocacy by whatever agency is working with them, and accountability. Standard of care at this point is 5 years, and the recovery rates, and you can look at different outcomes, but they're using kind of abstinence as a I would say a fairly important data point. At the 5-year mark, it eclipses everything, right? Everything else that we have seen. Right? Nothing really kind of comes close. We're looking at, I would say, in the 80s to 90% of the folks who are in this track do well, or at least are doing well at the 5-year point. There is understandable concern or pushback, because the piece that gets really honed in on is the accountability, and this wouldn't happen if there isn't this kind of top-down punitive approach. People's backs are against the walls, they don't have a choice. There is a lot to gain and a lot to lose, and we get that. I will tell you, we have seen people choose otherwise, right? And that in and of itself, I think, is important data because you're looking at how much value is given to the option and the ability to use a substance versus doing what they want to do in a safe way. And the kind of surveillance piece, it is important. It stops being the linchpin over time as folks get comfortable. But it is, as we all know, that following up with primary care is often, or at least yearly, or having some level of a touch point. It does keep this on everyone's radar, including the individual. It is not a crystal ball. This is not a magic wand that fixes everything. Our goal, and my goal when we have folks in treatment, is why should this just be relegated to a certain population? Shouldn't this be an option really for everyone? So what the Kool-Aid that we're trying to get everyone to drink, if you will, is this is data, right? We're appealing to your curiosity and your intellect, that this is something that is not a guaranteed done deal. But if you do, there is a higher percentage of success if you're following this as long as you can. And it's really not necessarily about, if you don't get to the 5-year mark, it's not worth it. It's any level of ongoing connection and accountability. Our continuing care process is, we shoot for 2 years post-treatment, and that's anyone, right? Safety sensitive or otherwise, and it becomes more of a carrot than a stick, because you have this family that's been in the trenches of treatment and is helping support you in the life of sobriety without really an active treatment team in play. Re-entry, and I promise we're near the end. Relief is in sight. So depending on what folks do, and especially from a professional standpoint, we're looking at stratifying risks. What sort of environment are they going into? Is there a way that you can, there's human nature to feel bad about being out of work. I need to get back in. I need to be hitting the ground running. Quite often that can backfire. And so we tell them rather to use us as the enforcers here, right? My clinical team says I need this accommodation for this long, right? Not working nights. I should work days. Need more administrative time. This is not something that is just going to magically go away unless I have the support. And we can back that up with documentation that they are legally kind of allowed to benefit from. Having a game plan and at times communication and corroboration. This is specifically when it comes to, I would say, safety sensitive folks. There's going to be some level of a monitoring entity involved. Have we talked about challenges, hurdles? Do they have enough support on site? Can we, the dynamic when it comes to, so going back to that PHP model, you've got an organization that has a job to do, that is to hold folks accountable, make sure that the public is safe. Can we set them up for success, knowing that dynamic can be challenging, and trying to kind of wade into that on the, I would say, the back end of treatment is important. And knowing that the treatment team, going back to the continuing care piece, is available and can kind of swoop in earlier than having to wait for someone to really, whether it's like a long-standing binge or really implode, right? If you can swoop in, you've got someone who's either testing or on a sober link, as opposed to a 15-day bender. You're in after a couple of days, additional support, we pull someone back on track. And so that's the goal, right? It's never really as neat or clean as that, and flexibility is really helpful. And really, I think we can always internally look at kind of how to improve this process. But again, the bigger picture there, I want to make sure that we have some time for questions as well. But I am effectively about wrapped up. That is my email address, folks, and we'll be able to find me and hunt me down whenever you need to. And if there are any questions that we don't get to here, I'm happy to do that as well. All right, I'm still on. Just talking to a screen for a while. Yes, I can put your email address in the chat. To streamline things, I think, yeah, we're going to use the chat, folks. Other apps, Jennifer, recovery, mood links. Okay, this is great. Thank you. I have heard of mood links. I want to check out Recovery Path as well. I'll put my email address in here. Just maybe rethought my voice being the only one that people can hear, but now here we are. Questions? Anything else that I can dive into? We should be able to get you slides and info that was asked. Reiterate the product that's being placed on legal documents. So this was when I mentioned this is basically what they're finding out, how drugs are being smuggled into kind of jail and prison settings. It's a variety of synthetic options, all the way from cannabinoids to cathinones are so basically like bath salts, if folks remember, really kind of profound, alteration, dissociation, synthetic stimulants, and opioids too. It's kind of terrifying, honestly, when you think about it, because you don't really know what you're getting or reading, and they found like books and legal documents too, and how much surveillance really can be effective. There's a whole industry too, and there's a lot more individual, like chemists or chemical analysts they call them, who are this was something that came up on New York Times recently, where they're getting shipments, they're kind of doing their own testing. Specifically, this was a cathinone that then they ship out and sell, and sometimes are sampling their own population. You don't want to kill off who you're trying to, I guess, alter, but it's scary, because there's a pretty narrow edge that you're trying to navigate there. Let me see here. Briefly touch on pornography addiction, best practices for treating this. So we, on the front end, we do a screener, and that would be not as thorough as it could be, but it looks at least, this is like a 6-question questionnaire of, is this coming up? Is this affecting you? Is this damaging relationships? And a lot of the times they're not going to say anything on the front end, and I get it. Who's going to open up as they're coming in? People are terrified. If we're paying attention and we're vigilant, this usually will come up. I didn't actually mention this, but there's such a crucial importance to family work when you're in treatment, and this is I would say we get so much information from partners and loved ones that may not come in. That's a time where some of this may come up, whether it's sexual compulsivity or pornography. There may be, so some of this may be paired with the substance. We pull the substance away and things improve in general. We may determine, or at least there's a question, that this may be an isolated issue in and of itself. And so CSATs, if you're familiar, certified sexual addiction therapists, are a godsend. They are, there's a lot of training that goes into specifically where they specialize in. So it is impractical for all of us to be able to treat all of this, but if at least we know, who do we refer to? Can we get an assessment? There's a lot of additional data that, and some of these assessments, including the SDI, which is the sexual dependency inventory, that is so deep and detailed, stuff that if we're not in that world, we're not really thinking of. Typically, there are, if you're looking at, trauma and attachment, I mean, there's a lot of factors that lead to where they are. We'll get some sort of an assessment or a verdict of, from a CSAT will say this is something we can work on an outpatient basis. We connect them. There's ongoing tracking. I mean, so for like pornography, I mean, there's apps that can be installed. There's ways to track internet use or limiting app use, or even going from, which is, I think, cool in general now, to go analog. And so maybe that's a guardrail that can be helpful. There can be scenarios where we just may not be able to contain, right? This is so active. You can say that someone is abstinent from alcohol, cocaine, methamphetamine, but if they're continuing to act out sexually, pornography or otherwise, there is no hope that we're going to get traction. And so then it's listen, your brain just needs some more containment and space, and that we can be a step down process, but there are really good kind of national programs that work with sexual compulsivity, including pornography addiction. This is different, and there is a distinction from predatory behavior and sexual compulsivity, right? So this is that is, and it's a treatment world that needs to exist. It is very different than what I'm talking about. And for a treatment setting and a clinical team, it can get real sticky, especially if it's a gray zone, because it's tough to find empathy for folks who you are viscerally uncomfortable with. And so that's another, hey, this is a program that does this and works with this. Let's get you over. And there may be a little bit of an overlap, but it really is a clear distinction. I hope that answers that question. GLP-1 research studies, if anything is being considered with co-occurring disordered eating. That is a huge area of, I would say, potential. That's kind of a game changer, but also really kind of risky as well, because if you have someone who's struggling with an eating disorder, anorexia or otherwise, and you are effectively amplifying their ability to kind of lean into what their illness is telling them, it's tricky, right? You can look at this as just another version of restriction, exercise compulsivity. There was, and there still is, there's people have used stimulants from an appetite suppression standpoint as a treatment. If you're looking at kind of binge eating use disorder, it is so risky. So to the question specifically, this is something that is continuing to be tracked. I don't know of any formal direction that we have received, but I imagine we're going to have to, with the eating disorder folks, hopefully kind of weighing in more. Is that the sexual addiction resources, Michelle, that you had asked for? We can, and there's kind of a compendium of info that we can send over for anyone who needs it, specifically if it's for CSATs or other. There's a lot of great community resources, meetings, if we're looking at SLAA in terms of sex and love addiction as well. Let me just make sure that I have not missed any other questions. I think that's it. And we have time to spare as well. We won't just awkwardly sit in silence forever, so we'll probably cut it at some point. Thank you, everyone, for taking the time. There are faces on here that are awesome to see, so much appreciated, and we should all catch up. And if anything else comes up, I am always available and happy to help. Thank you, everyone. Have a good rest of your afternoon. Take care. Thanks. Bye.